Everyone, so today we are going to study about the esophageal and esophagogastric junction cancer. So whenever any patient presents, first we will do some workups. So what all workups we have to do? First we have to physically examine the patient. We have to take history, then gastroduodenoscopy and biopsy whenever any lesion is visible. Then we do CT abdomen, pelvis, CT chest, and also we can get PET CT done if no evidence of M1 disease, and complete CBC, then EOS in case of there is no evidence of M1 unresectably. Endoscopic resection we can plan for early disease, biopsy of metastatic disease. Then we do other tests like microsatellite instability, PCR, NGS, IHC. PDL1 is indicated in all the newly diagnosed patients. HER2 testing is in case of advanced metastatic adenocarcinoma. NGS should be considered. Bronchoscopy when the lesion is at the level of carina or above carina. Then C-word staging category we will see later what is C-word. And nutritional assessment of the patient, smoking cessation, very important point. Entire family history and screening is necessary for any kind of distress. So according to the type of histology, whether it is squamous or whether it is adenocarcinoma, and depending on the stage, we'll plan the management of the patients. So if we did biopsy and it turns out squamous cell carcinoma, and the stage if it is 1 to 4A locoregional disease, except in case of T4B and N3 disease, we do a multidisciplinary evaluation of the case, consider for enteric feeding tube for preoperative nutritional support. So nutritional support is very important. And if patient is medically fit for surgery, we go for surgery in case of non-surgical candidate. So if in case of squamous cell carcinoma and we operated this patient for surgery, and what is the final pathology report? If it is TIS early stage, we keep patient for endoscopic resection or ablation, or we can go for esophagectomy. And in case of T1A lesion, similarly we can go for ablation or esophagectomy. T1B onwards we have to go for esophagectomy. For T1B to T4A lesion, and in case of N plus, we see for primary treatment. So in case of tumor, if it is T1B, T2 lesion, low risk lesions less than 3 centimeter, and if it is well differentiated, we go for esophagectomy. And then post esophagectomy we evaluate for further management. But in case of T2 and 0 or high risk lesion with high risk lesions, like if there is lymphovascular invasion present more than 3 centimeter in size, then poorly differentiated, or in case of T1B, T2 N plus disease, or in case of T3, T4 A and any, we need a pre-operative chemoradiation therapy or definitive chemoradiotherapy, and then we will go for response assessment. And if it is T4B disease, then we don't have any choice, we have to go for definitive chemoradiation, or we can consider for chemotherapy alone in the setting of invasion of the trachea, then great vessels or heart, and that is for palliative management. So nutritional prehabilitation is very important, so we can do by feeding jejunostomy, which is generally preferred. And histological confirmation of the suspected positive node is desirable. What all surgical techniques are there? So we can go for transhiatal or transthoracic or minimally invasive gastric reconstruction. For G junction and esophageal cancer, primary treatment for patients who are medically fit for with squamous cell carcinoma. So if we have given preoperative chemoradiation, then what we do FDG, PET CT, chest CT with IV or without with IV contrast, esophagoscopy, biopsy, and if it is suggested that there is no evidence of disease, we can go for a esophagectomy, or we can keep this patient under observation And if there is persistent local disease, then we have to go for esophagectomy, or we can keep this. If the patient is not a surgical candidate, then we can go for palliative management. In case of unresectable metastatic, there is palliative management. Now if the patient has undergone definitive chemoradiation, similar evaluation is done by FDG PET or CT chest, abdomen with IV contrast, and esophagoscopy biopsy. If there is no evidence of disease, we can keep this patient under observation, or if patient is fit enough to go for surgery, we can go esophagectomy. And persistent local disease, if it is there, then we will go for esophagectomy, or if the patient is not a surgical candidate, we can go for palliative management. And if it is progressive disease, in case of newly diagnosed metastatic disease, palliative management is the option. So if the post squamous cell carcinoma, if the patient have now R0 resection, then we have to keep this patient under observation. If it is R1 resection, then fluoropyrimidine based chemotherapy with radiation is the option, and for R2 resection, chemoradiation or palliative management we need to follow. Now patient have received preoperative chemoradiation, and post resection, if it is R0 resection and YP is T1, T0, N0, then patient is kept under observation. But any squamous cell carcinoma with post chemoradiation, if there is residual disease or node positive, then nivolumab is the category 1 recommendation. For R1 resection, we have to observe or palliative management, and for R2 resection also palliation is the option. So for squamous cell carcinoma, in case of TIS lesion, management of disease for non-surgical candidate, so we can go for ER or ablation for this patient. For T1A, endoscopic resection with or without ablation. For T1B, similarly we can do a endoscopic resection with or without ablation. For T1B, T4A, N0 or T4B, non-surgical candidate able to tolerate chemoradiation, then we can go for definitive chemoradiation. For non-surgical candidate and unable to tolerate chemoradiation, palliative radiation therapy or palliative best supportive care is the treatment. Usually follow-up is done every 3 to 6 monthly for first 1 to 2 years, then every 6 to 12 monthly for 3 to 5 years, and then annually using endoscopy, then biopsy, then nutritional assessment. We have to do CBC, imaging,